I'll be pleased to introduce Professor Valentin Kokorin, Professor of the Hospital Therapy Department at the Perkov Russian National Research Medical University. He is the Treasurer and Executive Committee member of the European Federation of Internal Medicine. Professor Kokorin today will start with the guidelines with regards to the appraisal and adaptation for internists on pulmonary embolism. Without any delay, Prof, you can start.
Okay, thank you, Mr. Chairman, my dear colleagues. First of all, I would like to thank the organizing committee for inviting me. And unfortunately, I'm the only one here representing the European Federation of Internal Medicine. Thus, I will start with a short introduction of our federation, which now composed 37 societies from 35 countries all over the world, not only European countries, and we are very optimistic looking for the collaboration and conversation with the Emirates Society of Internal Medicine, who can become an associated member of EFIM while you would like to join us. Indeed, we have a lot of kind of activities, except the executive committee, which I represent here. We have 7 working groups and subcommittees, the advice working group on vaccination, the Choosing Wisely working group, the working group working on critical appraisal of guidelines in internal medicine, the gender medicine working group, the quality of care and professional working group, and ultrasound working group. And also very active in our federation is the Young Internists subcommittee, and the next speaker, Professor Alberto Mara, who is the chair of this working group. I hope he will represent this group as well. Our flagship and our main event during the year is the European Congress of Internal Medicine, and next year will be the Jubilee, the 20th European Congress of Internal Medicine, which will take place face-to-face, we hope so, at the moment in Malaga, in Spain, on the 10th to 12th March. And I'm glad to say that the deadline for abstract submission was just yesterday extended, so you still have a possibility to send your scientific work and to represent it during the Congress, and you can see the website of the Congress as well here. But except the Congress, we have a lot of other kind of activities. For example, for more than 20 years, we are organizing the European Schools of Internal Medicine, mainly for young and early career internists. And due to the COVID pandemic, last 2 years, such meetings was cancelled. But next year, we're supposed to have 2 schools. The winter school will take place in Sweden, in the very far away place Björkliden, which is more north than the North Polar Line. It's the land of the polar lights and polar bears. So if you'd like to participate, it will be a unique experience for you. And the summer school will take place in Spain, in Escorial, in June 2022. So it's also a possibility to send your representatives and your participants to this wonderful course. It's usually continuous for a week, and it's a huge experience for young doctors to have a nice lectures, as well combined with the perfect outside activities. Another flagship of our federation is journals. We have 2 journals, the European Journal of Internal Medicine, and its editor-in-chief at the moment is Professor Giancarlo Agnelli from Italy. And this journal is in the first quartile of all general internal medicine journals in the world, and its impact factor is now close to 4.5. And another journal is a European Journal of Case Reports in Internal Medicine, and its editor-in-chief is Dr. John Kellett. And this is quite a unique journal which specialized only on case reports, and it's very well developed in the last years. And now it's also a place not only for case reports, but also became an abstract book for the European Congresses of Internal Medicine. And I would like also to announce another activity we just started a few days ago called EFIM Academy. This is an educational platform for internists all over the Europe. And you can find it on our website. It's just started, so we are really supposed that it will combine all the internists in Europe and outside as well. Coming back to the topic of my presentation, I will like to answer the question why pulmonary embolism became the focus of the first ever guideline product of the European Federation of Internal Medicine. First of all, because it's has very high incidence. It's globally the third most frequent acute cardiovascular syndrome behind myocardial infarction and stroke. It has quite high incidence rates and a tendency to rising in incidence over the time. It caused a lot of deaths in different countries, in USA, in Europe, and in all over the world. And what is very important, there is huge discrepancy between clinical and morphology diagnosis of this disease, and at least a third of all PA cases are diagnosed only post-mortem. So we suppose that pulmonary embolism represents a challenge for practicing doctors, clinicians, who often consult old patients affected with a number of comorbidities. And this can make clinical decision-making cumbersome in terms of diagnosis and treatment of approach. So the aim of our guideline appraisal and adaptation process was to adapt the existing recommendation from the existing clinical practicing guidelines to assist physicians in specific and complex scenarios related to acute pulmonary embolism. So there were a few stages on this process. The flow for adaptation procedure was at the beginning to identify the unsolved clinical issues in patients suffering from pulmonary embolism, then to critically apprise the existing guidelines, and to choose the recommendation which are the most applicable to the clinical practice. So indeed, this is not the guidelines created by the federation itself. It is more the adaptation and appraisal of the existing guidelines of other societies. And for this purpose, the task force was created, combine a few world-known experts in this area, Professor Cecilia Beccatini from Italy, Professor Antonio Riera from Spain, the president of the European Federation of Internal Medicine, of course, Professor Dror Dicker from Israel. Also, we had several very well-known specialists in evidence-based medicine and in methodology of evidence-based medicine, Dr. Victoria Lesniak from Poland, Professor Ignacio Marin from Spain, and Javier Medrano from Spain, and also several members who are also specialists in this area, but not so well-known. We started with the organization of the survey, internet survey among the internists. What are the most difficult issues in the diagnosis and management of the patients with pulmonary embolism? And so far we had approximately 400 answers from the internists all over Europe. And we selected, combined some questions, and finally we created a list of 5 the most difficult and the most interesting key clinical questions, which called PICOS. This is the abbreviation. And this PICOS became the subject of our further analysis and search. So the first question is how to rule out pulmonary embolism in case where CT scan is not available or contraindicated in a population where D-dimer is unreliable. This is the case of chronic kidney disease, elderly patient, pregnant patient, and so on. The second key question was how to treat patients with pulmonary embolism with their special conditions like pregnancy, high-risk bleeding, anemia, thrombocytopenia, cancer, chronic kidney disease. The third question was which is the best bleeding prediction rule in a comorbid patient treated for pulmonary embolism. The fourth question was what should be the optimal duration of anticoagulation after pulmonary embolism, including patients with some special populations. And the last question was, do we really need the screening for cancer and thrombophilia in pulmonary embolism patients without recognized thrombosis risk factors? So what we did afterward, we made a search through the internet of different records and in the database, the Medscape and so on, Midline, Embase and Scopus, and identified approximately more than 3,000 papers with the keywords of pulmonary embolism, but most of them was not reliable to our questions. So finally, after all exclusion, we had 11 documents which became the field of our interest, which had the answers to the questions we had at the beginning. When we analyzed the evidence in every guideline and we interpreted it due to the quality of evidence and due to the strength of recommendation in the PRISMA process and the grade system, and we differentiate all the existing statements as a high, moderate, low, very low quality level, and as strong recommendation or weak recommendation or good practice statement. So what was the result? And I would like to say that this document was first time announced on the European Congress of Internal Medicine in March this year, but still today it was not published yet. It was accepted by the European Journal of Internal Medicine, is under correction now, so I hope very soon it will be officially published in the European Journal of Internal Medicine. But so far we had already all the document ready. So the first question, how to rule out pulmonary embolism if CT scan is not available or contraindicated in a population where D-dimer is non-specific, and we had the following answers. In patients with contrast-induced allergy or in patients with renal impairment, it is suggested to start with the ventilation perfusion scanning in a population with a low or intermediate prevalence pre-test probability of pulmonary embolism. In case of high prevalence or pretest probability of pulmonary embolism, non-diagnostic scan are should be followed by additional tests. And it has quite weak and very low to moderate quality of evidence. A baseline chest X-ray might identify an alternate diagnosis and potentially avoid further diagnostic imaging, but this is also a good practice statement. We also can say that if clinical suspicion of pulmonary embolism is low, we can consider using the PERC rule to help determine wherever and any further investigations for pulmonary embolism are needed. And if there is a low risk due to this rule, we can exclude the diagnosis of pulmonary embolism and don't use any other diagnostic methodics. For pregnant patients, it is suggested to use the ventilation perfusion lung scanning, our CTPA, in case when a low radiation protocol is not available. But if it is available, of course, we should consider it to rule out pulmonary embolism. We also mentioned that in a pregnant patient with suspected pulmonary embolism, especially if she has symptoms of deep vein thrombosis, venous ultrasound should maybe considered to avoid any further unnecessary radiation. But the power of this, the evidence base of these guidelines is weak, and the quality of evidence is quite low as well. So this is the algorithm, the diagnostic approach to a patient with suspected pulmonary embolism in case where D-dimer results are not specific and CTPA is not available or contraindicated. And this is summarized the statements which I told you before. The second question, how we should treat the patients with some additional conditions, some comorbidities, and the first such comorbidity is cancer. So what we know about the treatment of pulmonary embolism in patients with cancer? Initial treatment of pulmonary embolism include direct oral anticoagulants, and for today there is a good evidence base for apixaban, edoxaban, and rivaroxaban. Or we can use low molecular weight heparins for initial treatment. And this is a strong recommendation with the moderate quality of evidence. And it was just announced in the currently available, currently produced guidelines of American Society of Hematology. We know that low molecular weight heparins are recommended over unfractionated heparin for initial treatment of PA patients with cancer. It is suggested to use low molecular weight heparins over fondaparinux for initial treatment for such patients. And we know that thrombolysis can only be considered in case-by-case basis, where with specific attention to contraindication, especially to the bleeding risk. Primary treatment, which means the treatment up to 6 months since the beginning of pulmonary embolism, and secondary prevention beyond this period, we had concluded the following statements. Direct oral coagulants or low molecular weight heparin should be used for a minimum of 6 months to treat established pulmonary embolism in patients with cancer, of course, with the acceptable value of creatinine clearance. Beyond the initial 6 months, extended anticoagulant therapy should be offered to selected patients, patients with continuing cancer disease, to the patients who are still receiving chemotherapy or have metastatic disease. And termination or continuation of anticoagulation should be based on individual evaluation. And what is very interesting, the very interesting statement concerning the recurrence of pulmonary embolism in patients who are already receiving anticoagulants. There are some answers. How can we manage such patient in case when the patient are taking low molecular weight heparins? We can try to increase the dosage to 20–25% or switch such patients to direct oral anticoagulants. For patients who are already taking DOACs, we can switch them to low molecular weight heparins, and for vitamin K antagonist receivers, we can switch them to low molecular weight heparins or direct oral anticoagulants. How to treat the patients with the other comorbidities? For patients with pulmonary embolism and advanced and severe chronic kidney disease, we can conclude that it is suggested to use unfractionated heparin followed by early vitamin K antagonists or low molecular weight heparins for treatment of established pulmonary embolism. The evidence based of direct oral anticoagulants in this category of patient instead of atrial fibrillation is very, very low. So we do not recommend to use direct oral anticoagulants in this category of the patients. For pregnant patients, low molecular weight heparins are recommended over unfractioned heparin. Intravenous unfractioned heparin can be recommended in patients who may require thrombolysis, surgery, or urgent delivery. And we should note that direct oral anticoagulants or even vitamin K antagonists should not be used in pregnant patients. We are not recommending to use routine monitoring of anti-10A factor levels in patients who are receiving low molecular weight heparins. And also we have a few statements concerning the treatment of patients with pulmonary embolism and thrombocytopenia. There are very low evidence base for such patients, but it still exists, already exists in the International Society of Thrombosis and Hemostasis guidelines and in some other research papers. For those patients who had the level of platelets exceeding 50,000 per milliliter, the conclusion is that we can use the therapeutic doses of anticoagulation. For patients with the level of platelets between 30 and 50,000, we should use decreased dosage of anticoagulation, half dose of anticoagulants. And for patients with severe platelet thrombocytopenia, we should discontinue anticoagulation or use maximum prophylactic doses of anticoagulants. We should think about necessity of emplacement of cover filters and about necessity to transfuse the platelet mass. There is unfortunately no statements, no guidelines dedicated to the question how we should treat the patients with pulmonary embolism and anemia. Current available guidelines are not focused on this issue, so it should be the subject of further investigations and scientific research. The third PICO was dedicated to the bleeding prediction in comorbid patients treated for pulmonary embolism. And the conclusion is not too much optimistic. There are currently no validated prediction tools to stratify the risk of major bleeding during extended anticoagulation, specifically, which are specific to the patients with venous thromboembolism. But there are some statements in two guidelines which may be opening some small light to this issue. British guidelines, NICE guidelines of 2020 said that we can consider using the Hasbled score for risk bleeding evaluation in people who are anticoagulated for pulmonary embolism or deep vein thrombosis. But this score is not sufficiently accurate and not validated to be used as the sole basis for this category of patient. And the second option is to risk a score of different risk factors such as age, cancer, metastatic disease, chronic appearance of chronic renal or hepatic failure, level of platelet, and requires of antiplatelet therapy, history of bleeding without a reversible cause, and we can identify the patients with a low risk, moderate risk, and high risk, dependent on the number of these risk factors. But this is just a good practical statement, and it has no more evidence to be used. So this is also a question for further investigation, the prediction of bleeding in such category of patients. The next question was dedication to the optimal duration of anticoagulation after episode of acute pulmonary embolism. And there is quite clear position in the world that the course of anticoagulation should be at least 3 months due to European Society of Cardiology guidelines, or from 3 to 6 months from the American Society of Hematology guidelines. And what to do afterward? Afterward, we should evaluate what was the reason of the pulmonary embolism. Are there any provoked or risk factors? And in case of presence of a chronic risk factor, it's necessary to continue the antithrombotic therapy indefinitely, unidentified long or extended antithrombotic therapy. For pulmonary embolism provoked by a transient risk factor, we can discontinue the anticoagulation in 3 months only in the case of it was a transient major risk factor which disappeared during this period, like major surgery or some timely immobilization which was resolved. For all other cases, extended oral anticoagulation of indefinite duration should be considered. And also the same story for unprovoked pulmonary embolism. The duration of anticoagulation in such patient should be indefinite long. So this is the algorithm how we should select the duration of anticoagulation in patients with the pulmonary embolism after completion, of course, primary treatment of 3 months at least. And finally, the last PICO was dedicated to the necessity of screening for cancer and thrombophilia in pulmonary embolism patients without recognized thrombosis risk factor. And the conclusion is that for the screening for cancer should be offered only a limited one, including medical history, physical examination, full blood count, renal and hepatic function, and evaluation of APTT. In patients with unprovoked pulmonary embolism who are not known to have cancer. And extensive screening, including CT scan, should be recommended only if there are any clinical symptoms or signs suggestive for cancer. And similar story for thrombophilia. We are not supporting the idea for thrombophilia screening for patients who are continuing anticoagulation, and for those as well who had provoked deep venous thrombosis or pulmonary embolism. And we can consider testing for hereditary thrombophilia in patients who have unprovoked pulmonary embolism and have a first-degree relative, and to those who are planned to stop anticoagulation treatment. For all other categories, the full screening for thrombophilia is not recommended. And in the end, I would like to thank for the possibility and to acknowledge you with one more Congress, which will take place next year, and it will happen in Moscow, in Russian Federation, and it will be the World Congress of Internal Medicine. The time point is mid-October 2022, and you can see the website here, so I hope to welcome you on the World Congress of Internal Medicine next year in Moscow. Thanks a lot for your attention.